A very warm welcome to you guys. Today we are going to discuss this first topic in this pathology discussion, that is cell injury and adaptations. So we're going to see some basic infos about the cells injury, how the cells are injured and how they are adapted. Let's start with some basic causes of cell injury. Causes of cell injury. First cause of cell injury we're going to see is hypoxia. First cell injury is hypoxia. Hypoxia, very simple way, means decreased oxygen supply to a tissue or organ. Very simple, hypoxia is decreased oxygen supply to a tissue or organ. Now this hypoxia is the most common cause of cell injury. Hypoxia is the most common cause of cell injury. Next, this hypoxia is the most common cause of hypoxia. Hypoxia, its most common cause, as you remember, is ischemia. Simple understanding, nothing fancy. Ischemia is the most common cause of hypoxia. What is meant by ischemia is simple. This is decreased blood supply. Ischemia means decreased blood supply. Next we are going to see cells most affected by hypoxia, or cells most sensitive to hypoxia. This is our neurons. This is our neurons. Brain is the most affected in this hypoxia, so neurons, cells which are most sensitive or most affected by hypoxia. Then cells least sensitive, least affected to hypoxia. Remember, these are the fibroblasts. Fibroblasts or skeletal muscles. Least sensitive to hypoxia, fibroblasts or skeletal muscle. Most sensitive or most affected by hypoxia, neurons. Least sensitive, fibroblasts or skeletal muscles. Next, we are going to see some other causes of cell injury. First we have seen hypoxia. Next we are going to see some other causes. Other causes are physical injury agents. Physical injury agents, for example, radiation. Examples of physical injury agents. Third, we have chemical injury agents. For example, carcinogens. Example is carbon tetrachloride, CCl4. Carbon tetrachloride. The carcinogen is an example of chemical injury agent. Fourth one are infectious agents. These are bacteria, viruses, parasites. Bacteria, viruses, parasites are infectious agents. Then is the genetic abnormalities. Next is immunologic abnormalities. Immunologic abnormalities. Next, last one, nutritional imbalances. Nutritional imbalances. So these are some examples of cause of cell injury, hypoxia. Then there are physical injury agents such as radiation, chemical injury agents such as carbon tetrachloride, infectious agents we all know, bacteria, virus, parasites, they invade our body daily, genetic abnormalities, immunologic abnormalities such as autoimmune disorders, and nutritional imbalances. So now we're going to discuss proper cell injury. Cell injury. So cell injury we're going to discuss. Under the cell injury we are going to discuss a lot of points. Let's see. We are going to see some adaptations. Adaptations, for example, hypertrophy. Next is hyperplasia. Next is metaplasia. Next is atrophy, hypertrophy, hyperplasia, metaplasia, and atrophy. These are the adaptations during the cell injury. Next, we will discuss reversible cell injury. Reversible cell injury. After the cell injury, upon removal of the injury causing agent, the cell goes back to normal. This is reversible cell injury. Then is the irreversible cell injury. Irreversible cell injury. In this irreversible cell injury, cells die. Reversible cell injury, cells doesn't die. Irreversible cell injury, cells die. There are 5 main process through which cells die. There is necrosis. There is apoptosis. There is necroptosis. There is pyroptosis. Last one is ferroptosis. Ferros, this is the iron. Ferroptosis, pyroptosis, necroptosis, apoptosis, and necrosis. After irreversible injury, we are going to see some pathologic calcification. Then we are going to see some intracellular accumulations. So some adaptations. Then reversible cell injury, irreversible cell injury, pathologic calcification, that is accumulation of calcium pathologically, which is often damaging, and intracellular accumulation of some substances like lipids, like proteins, abnormally folded proteins, etc. So in this video we are going to solely discuss these adaptations: hypertrophy, hyperplasia, metaplasia, and atrophy. So let's discuss them one by one. The first I want to discuss is hypertrophy. We are discussing cell adaptations. This first we are going to see is hypertrophy. This hypertrophy, what we mean by this hypertrophy? The definition is increased cell size but no increase in number of cells, which leads to increased size of organ. In hypertrophy, final conclusion is increased size of organ. Why? There is increased cell size without any increase in number of cells. Important to remember. There is increased size in organs due to increased cell size but no increase in number of cells. Now the mechanism of hypertrophy, that is increased synthesis of cellular proteins. There is increased synthesis of cellular proteins. Some examples we are going to see. This is given in the Robbins. You synthesis of cellular proteins such as, remember, GATA4, then NF80 and MEF2. GATA4, NF80 and MEF2. These are some of the cellular proteins that does increased synthesis leading to hypertrophy. This hypertrophy next we want to see is usually occurs in permanent or non-dividing cells. This occur in permanent or non-dividing cells. For example, myocardial cells. These myocardial cells are example of permanent or non-dividing cells. This hypertrophy usually occurs in permanent and non-dividing cells. Important point to remember. We are going to see some examples of hypertrophy. Examples of hypertrophy. Under this, we are going to discuss two types. Okay, there are two types of hypertrophy. Very simple. First one is physiologic hypertrophy. Next is pathologic hypertrophy. Examples of physiologic hypertrophy are, remember, uterus during pregnancy. Next example is breast during lactation. The third one is in bodybuilders, skeletal muscles. The bodybuilders, the skeletal muscle of the bodybuilders. It's an important example of physiologic hypertrophy. Also uterus during pregnancy and breast during lactation. Remember, there is three examples of this breast. Is breast during lactation, breast during pregnancy and breast during puberty. We are going to see that breast during puberty and breast during pregnancy are examples of hyperplasia. For now, remember, breast during lactation, very important, is an example of hypertrophy. So uterus during pregnancy and skeletal muscle in the bodybuilders. These are physiological examples of hypertrophy. Pathological examples are, first remember, hypertension leading to left ventricular hypertrophy. Hypertension of the heart, we have seen here, it usually occurs in permanent or non-dividing cells. For example, the myocardial cells. Hypertension often affects the myocardial cells. Left ventricular hypertrophy, very important example, remember. Next is stone in urinary bladder. This leads to damage in the area proximal to obstruction, undergoes hypertrophy. Suppose this is the urinary bladder. You see, this is a diagram of urinary bladder. Here, stone is developed. So this obviously obstructs the flow of urine. Now the area proximal to the obstruction, this area proximal to this obstruction undergoes hypertrophy. Area proximal to obstruction undergoes hypertrophy in stone in the urinary bladder. So we've seen some of the examples of hypertrophy, physiologic and pathologic examples. This is the mechanism behind hypertrophy. It is increased in the synthesis of cellular proteins. Remember, it usually occurs in permanent or non-dividing cells, for example myocardial cells. Next we are going to see is the second adaptation. It is hyperplasia. Hyperplasia, I'm going to see the definition. There is increase in number of cells. Here in hyperplasia there is increase in number of cells, ultimately leading to increase in size of organ. Increase in number of cells leading to increase in size of organ. This is hyperplasia. Now the mechanism is due to, remember, growth factor induced proliferation of mature cells. Is induced by the growth factors. There are certain growth factors released. This growth factors induces the proliferation of mature cells, which leads to increase in the number of cells and increase in size of organ. Important point to be noted here, it occurs in dividing cells. So we have already seen two differences between hypertrophy and hyperplasia. Hypertrophy, there is increase in cell size but there is no increase in number of cells. Hyperplasia, there is increase in number of cells. Second, in hypertrophy, it occurs usually in permanent or non-dividing cells. Here in hyperplasia, it occurs in the dividing cells. Now, I'm going to see the examples of hyperplasia. Same pattern will be followed here. There are some physiological examples and pathological examples. Physiologic, physiologic and pathologic. In this physiologic, we have again two subdivisions. First is hormonal. First is this hormonal induced. Second is compensatory. Physiologic hyperplasia subdivided into hormonal and compensatory. Hormonal example is, as I have said before, breast during puberty and pregnancy. In hypertrophy, we have seen physiologic hypertrophy, breast during lactation. Physiologic hyperplasia, that is under hormonal influence, breast during the puberty and pregnancy. Very, very important difference, remember. The compensatory example is liver after partial hypertectomy. Liver after partial hypertectomy is a compensatory physiologic hyperplasia. We are going to see pathological. Pathological are generally hormonal induced. Hormonal induced. We are going to see the two types of hormones in males and females. In males there is these androgens, due to the androgens, and in females there is due to estrogen. In males due to androgen there is very common BPH, that is benign prostatic hyperplasia. Benign prostatic hyperplasia, BPH, due to androgens in the males. In females due to estrogen there is endometrial hyperplasia. Endometrial hyperplasia. Due to androgen in males, benign prostatic hyperplasia, BPH. Remember one important point given in the Robbins, that hyperplastic proliferations are a fertile soil. You know this word, fertile soil, in which cancers can develop. Hyperplastic proliferations are a fertile soil in which cancers can develop. For example, take an example of a cancer, that is endometrial cancer. Endometrial cancer, we have seen with this estrogen hormone effect, pathological endometrial hyperplasia can occur. This endometrial hyperplasia can sometimes lead to endometrial cancer. Under this endometrial hyperplasia, this acts as a fertile soil. This acts as a base for which endometrial cancer can develop. These hyperplastic proliferations are a fertile soil in which cancers can develop. See this example of endometrial cancer. Next question we often get, that examples of both hyperplasia and hypertrophy. Very important question. Examples of both hyperplasia and hypertrophy. Remember, breast during puberty and pregnancy. We've seen here before, breast during puberty and pregnancy is an example of physiologic hormonal induced hyperplasia. But sometimes breast during puberty and pregnancy also shows some examples of hyperplasia and hypertrophy. Why I am saying, we will learn later. Another example is uterus during pregnancy. Uterus during pregnancy. Actually, in the Robbins, it's written that both these hyperplasia and hypertrophy can coexist sometimes. That's why these two examples are more commonly given as examples of both hyperplasia and hypertrophy. Breast during puberty and pregnancy. Remember, hyperplasia P. So breast is during puberty and pregnancy, both P. Hyperplasia P, puberty and pregnancy. The lactation is hypertrophy, and uterus during pregnancy. We often give both these examples are both hyperplasia and hypertrophy. So this is all about hyperplasia. Next we are going to discuss is atrophy. Discuss is atrophy. This atrophy, the definition there is decreased cell size. Decreased cell size also combined with decreased cell number. This both decrease in cell size and cell number, ultimately leading to very simple decreased size of organ. Decreased size of organ, decreased cell size, also decreased cell number, leading to decreased size of organ. Is the definition of atrophy. So now the mechanism here is, first is decreased protein synthesis. There is decreased protein synthesis. Proteins are the building blocks of the cell. Cells are made up of proteins. One of the structural building blocks of cell is protein. So decreased protein synthesis leading to decreased size of the cell and organ eventually. Then there is increased protein degradation. Increased protein degradation. Third one, C is autophagy. This phenomenon of autophagy leads to decreased cell number and decreased size of organ. The other two are decreased protein synthesis and increased protein degradation. These are the mechanisms of atrophy. So eventually we are going to see some examples of atrophy. Obviously there is physiological and pathological. These two distinctions are very important everywhere. Physiological and pathological, very useful for diagnosis also. We will learn further how very important. So physiological examples of atrophy are disappearance of notochord, thyroglossal duct, at puberty. The disappearance of some structures or organs from body is an example of physiological atrophy. This notochord, from this notochord spinal cord develops. There are structures such as thyroglossal duct. They disappear at puberty. This is an example of physiological atrophy. Next is involution. Involution, that is shortening of the uterus towards the inside. Involution of uterus, when after parturition there is involution of uterus. So this is an example of physiological atrophy. Now an example of pathological atrophy, that is aging, called senile atrophy. Senile atrophy or aging. Then there is ischemic atrophy. Then there is denervation atrophy. A certain nerve is damaged. Structures supplied by this nerve are not used for a long time, leading to denervation atrophy. Then there is pressure atrophy. Then there is, as we have said, organ disuse atrophy. Pressure atrophy, denervation atrophy, ischemic atrophy, senile atrophy, called aging. These are pathological examples of atrophy. And the last example of this pathological atrophy is nutritional atrophy. Cells, organs, tissues, organ systems are dependent on nutrition. Minerals, vitamins. If there is nutritional deficiency, can lead to nutritional atrophy. Fourth cell adaptation we're going to see. Here is fourth one is metaplasia. From this word we can also understand metaplasia. Definition we're going to see. Definition is a reversible change in which there is one differentiated cell type. Differentiated cell type is converted to another cell type. It's a reversible change. This metaplasia is a reversible change in which there is conversion of one differentiated cell type into another cell type, which means cells combine to form tissues. There is conversion of one type of tissue to another. Conversion of one type of tissue type to another. To see the mechanism. Mechanism is due to reprogramming of the stem cells. From the stem cells, the cells originate from a particular stem cell, a particular type of cell is generated, which forms a particular type of tissue. So when this reprogramming of the stem cells and altogether different type of tissue and cell type is formed. We will see some very important examples here, clinically important examples. First one is pseudostratified ciliated columnar epithelium. Pseudostratified ciliated columnar epithelium wherein respiratory tract. We know the respiratory tract contains pseudostratified ciliated columnar epithelium. This epithelium, when we smoke, we use cigarettes. This epithelium, when we smoke, is converted to, remember, stratified, from pseudostratified to this type, stratified squamous epithelium. From ciliated columnar to squamous, and altogether different type of tissue and cell type. Due to smoking in the smokers, the pseudostratified ciliated columnar epithelium respiratory tract is converted to stratified squamous epithelium. Why? We have seen the mechanism here, due to deprogramming of the stem cells, which is the stimulus for reprogramming. This is the smoking. This is called, remember, this is called squamous metaplasia. Squamous metaplasia. Stratified squamous epithelium is formed, so it's called squamous metaplasia. This is one example. Next, another important example we are going to see, very clinically relevant example. Barrett's esophagus. Barrett's esophagus. What happens here in this Barrett's esophagus? We know that esophagus. This esophagus is lined by certain type of cell and tissue. Under the microscope, we see certain type of cell and tissue. What is this tissue? This is stratified squamous epithelium. This stratified squamous epithelium. This stratified squamous epithelium cells gets reprogrammed by a stimulus. What stimulus? The stimulus is called GERD, GERD, which stands for gastroesophageal reflux diseases. There is reflux of acid from stomach to esophagus. The acid is powerful, strong acid. It's refluxed from the stomach to esophagus. This could be due to various reasons. Sometimes due to failure of sphincters doesn't work properly. Maybe due to some other reasons. Remember, this is due to the stimulus is GERD. Due to this reflux, the stratified squamous epithelium, remember, it's converted to columnar epithelium. Columnar epithelium. Stratified squamous epithelium, it's converted to columnar epithelium. This condition is called as Barrett's esophagus. This is also called as columnar lined esophagus. Barrett's esophagus is also known as columnar lined esophagus. Esophagus is finally lined by columnar epithelium, so columnar lined esophagus. This is also called, as we have seen in the example before, columnar metaplasia. Columnar metaplasia. Columnar epithelium replaces this stratified squamous epithelium, so called columnar metaplasia. Further, we are going to see there are a large number of goblet cells. Large number of goblet cells in columnar epithelium. Large number of goblet cells in columnar epithelium. This is Barrett's esophagus. When you see under the microscope, you will see the histopathology finding that there are large number of goblet cells. Remember, goblet cells. So, under this HNE, that is the histopathological finding, the hallmark of Barrett's esophagus. Hallmarks of Barrett's esophagus. First is intestinal metaplasia. We know this columnar epithelium is found in the intestine. So the columnar cells will be seen under the slide in the microscope. So it's called intestinal metaplasia. Next is the, obviously we have discussed, presence of goblet cells. Goblet cells will be seen in the histopathology under the microscope. These are two the hallmarks of Barrett's esophagus. For this, we require a special stain for Barrett's esophagus, particular to detect these goblet cells. We see the special stain for Barrett's esophagus. Remember, Alcian's blue. This is a special stain for Barrett's esophagus. Why? Because it stains the mucin in the goblet cells. Alcian's blue has a special affinity for mucin. This mucin is present in large amount in the goblet cells, and these goblet cells are a hallmark finding of the Barrett's esophagus. So during diagnosis, we use this special stain, Alcian's blue, to detect the mucin in the goblet cells and to possibly diagnose that is a case or condition of Barrett's esophagus. This further we are going to discuss that this Barrett's esophagus is a risk factor for, remember, adenocarcinoma for esophagus. It is this adenocarcinoma, carcinoma of glands. Carcinoma of glands referred to as adenocarcinoma. Barrett's esophagus is a risk factor for adenocarcinoma of esophagus. Which gland? The goblet cells is accumulated. This is a risk factor for adenocarcinoma of the esophagus. Next we are going to see some points in this metaplasia, that vitamin A, that is our retinoids, vitamin A deficiency can lead to metaplasia. Vitamin A deficiency, retinoids deficiency can lead to metaplasia. Last example we are going to see an example of connective tissue metaplasia. This one is particularly given in the Robbins. Is an example of connective tissue metaplasia. Remember, connective tissue metaplasia, an example is myositis ossificans. In the skeletal muscles, this myositis ossificans occur. This is an example of connective tissue metaplasia. With this, we conclude our discussion on metaplasia. In this video, we have seen, in the beginning, we've seen cell injury, causes of cell injury. One of the most common causes, an important cause is hypoxia. Then we've seen what happens in cell injury. There are adaptations, reversible, irreversible cell injury, and also there is calcification, pathology calcification, and intercellular accumulations. Then we've seen different types of adaptations. It's hypertrophy, definition, mechanisms, pathological and physiological examples. Hyperplasia, same things. There is atrophy, physiological and pathological. Finally, metaplasia. Metaplasia, we've seen two examples: respiratory tract and Barrett's esophagus. Very, very clinically important. Special stains used, the hallmark findings: risk factor for adenocarcinoma of esophagus, and also myositis ossificans. This is all for this discussion on cell injury adaptations. Make sure to revise them, guys. Thank you. I will catch you in the next one. Good luck.